All right, kia ora koutou. Today we've got several speakers with us representing a collaboration between the Ministry for Pacific Peoples and Better Start National Science Challenge. So our speakers today are Barry Milne here, Director of Compass and part of the Big Data team for A Better Start, Ata Forrest and Anita van der Veer from the Research and Evaluation team at the Ministry for Pacific Peoples, and Jesse Kokoa and Troy Ruhe from Va'o Tautai, the Centre for Pacific Health at the University of Otago. And Jesse's also part of A Better Start Big Data theme, and I believe they're joining in on Zoom, is that right?
Yep, wave.
Thank you. The flyer and the Compass seminar page is a bit more detail on everyone's backgrounds and research interests as well, if you're interested. And today, our speakers will talk to us about their research, examining the characteristics of Pacific peoples with mental health conditions using data from the New Zealand Health Survey, with, I believe, the goal of also incorporating a Pacific perspective into the study. So this will be really interesting. And I'll pass over to you, Barry.
Okay, thank you. Kia ora, talofa, kia orana. Maybe I'll just minimize this. Yes, we will incorporate a specific perspective, which we'll get onto shortly, the tivaivai method, which Jesse helped put together with Terry Moana Maua Hodges developed the method. So the tivaivai is a traditional quilt. That's one. Was that one that was provided to you, or that's just a picture one? That was one
provided by Mama Marine.
Mama Marine, great. So in my wildest dreams, I thought we could actually have an actual tivaivai here behind us when we're presenting, but that's not going to be the case. Anyway, I'll get onto that. And yes, this has been a really fun collaboration as part of the Better, on my side, part of the Better Start National Science Challenge, and also Ministry of Pacific Peoples. So this is our group really. So myself here from the University of Auckland, Ata, Kathleen and Anita from Ministry for Pacific Peoples, and Jesse from the University of Otago. This is where we had a planning meeting in Dunedin. And actually, I can't say that we can't see the sun in Auckland at the moment, but mostly we haven't been seeing the sun in Auckland. And it was absolutely fantastic day down in there. That's on, for anyone who knows, that's the staff club looking out towards down Castle Street. Okay. So that's us. And also Troy was, I think, was away overseas at that time, but he's also involved in this project, did a lot of the work on the literature. So we sort of slotted them into the trees there. So yeah, that's us. And how this came about was we at Better Start, the Better Start Big Data theme, do work using whole population data to understand various aspects of human development. Healthy weight, well, our main areas are healthy weight, resiliency in teenage years, and successful learning. And we wanted to work on a project that was specific to Pacific in the big data area. And after a few backs and forths, we got together with the Ministry for Pacific Peoples to do this particular work. And what they decided they wanted to do is look at mental health in the Pacific population, not just in early years, as Better Start has a focus of, but across the whole life course, which we're very happy to do. So yes, partnership between MPP and Better Start Big Data team. And one of the backgrounds to this, it's the first time since Te Reo Hinginaro, which I think Jesse might have worked on actually, which is 20 years ago now. So it was a nationwide mental health survey that had, I'll get onto it shortly, had decent numbers of the Pacific population. I'll get onto it shortly as well. The New Zealand Health Survey doesn't have that good numbers to do a lot of things that we wanted to do, but we tried our best anyway. So it focuses on, as I say, adults and children and their mental health using the New Zealand Health Survey. So the New Zealand Health Survey is a population-based survey that represents the population of New Zealand, so you can weight it up to get numbers for the whole population. Accessed through the integrated data infrastructure, which we access through a data lab here in the adjacent building. And from the MPP side, they want to explore Pacific mental health in alignment with our goals and the Ministry's Langa Whao goals. That's fine. And because we're using the IDI for a lot, but not all of these analyses. But there's a disclaimer here saying they're not official statistics. Any mistakes there are ours, not Stats New Zealand or anyone else's. Okay, so these are Lalanga Whao goals, yeah, of the Ministry of Pacific People. So thriving Pacific languages, cultures, and identities, prosperous Pacific communities, and the two that we're focusing on for this particular project, resilient and healthy Pacific peoples, and confident, thriving, resilient Pacific young people. Okay, so we in this project meeting 2 of the 4 goals of the Ministry of Pacific Peoples. And I alluded to this before, but from our perspective, we work in the area of trying to understand resilient teens, healthy weight and successful learning. And we particularly wanted to do a project focusing on Pacific, and this was that project. Focusing on resiliency really, while investigating associations with learning education. We didn't manage to work in the healthy weight thing. We've done a lot in the healthy weight area. I think it's fair to say as part of the big data theme of the Better Start National Science Challenge. Okay, so just some background about the Pacific population of New Zealand. 381,000 as at the last census. The latest figures haven't come out yet, representing a number of different ethnic groups, the largest being Samoan, and you've got all the other groups going down there, Tongan, Kukai, Māori, Niuean, Fijian, etc. I should always also mention Tokelauan because we're doing a little bit of work in that area. Multi-ethnic population, so 41% report at least one other ethnicity at the level 2 level, so they might report Samoan and Tongan, but also Samoan and New Zealand European, or Samoan and Māori, and that sort of thing. A very, very young population, median age 23.4, which is the youngest by some way of all the level 1 ethnic groups in New Zealand, the European, Māori, Pacific, Asian, Mila, Middle Eastern, Latin American, African, and other. So to give you a comparison, the European median age is 41. Third of the population under 15, and as an aside, just think about what that means when it comes to the election this year, that more than a third of the Pacific population has no opportunity to vote. I think it's around 40% or something. I did some investigation of that. Yet they all need to be represented. 2/3 live in Auckland. 2/3 are born in New Zealand now. So it's less so an immigrant population than what it was 30 years ago, when a lot of this research started to be done on mental health, and 20 years ago when the mental health survey was done. A population with high unmet health need, and a population that tends to have the greatest socioeconomic challenges of any ethnic group in New Zealand. In terms of Pacific mental health, early studies, and by early I meant the 1990s, indicated high levels of psychological distress amongst the Pacific population. There's a suggestion that, or work really, not a suggestion, work done suggesting that immigrant experiences such as living conditions, discrimination, and adaptation to the New Zealand context contributes to mental and physical distress in the Pacific community. Despite high levels of psychological distress, diagnosis rates tend to be lower. Around half of non-Pacific, half of Māori, half of European. The Te Rau Hingangaro, and as I say, 20 years ago, had 13,000 adults, including a good chunk, 2,374 Pacific adults, which I should point out is greater than the share in the population, which is the way surveys should be done. But anyway, and that reported higher psychological distress, higher alcohol and drug use, lower service use in the Pacific populations. Because it was a survey, they didn't look into the why, but other subsequent studies have looked into the why, including a lot of work out of the Pacific Island Family Study, suggesting that there's unfair treatment in health settings for Pacific. There are access barriers and health literacy issues about knowing how to access services. And also there may be stigma associated with accessing services for mental health, and also preferences of not necessarily accessing services for mental health, getting help within the family, for instance. and also higher rates of distress diagnosis among the New Zealand-born population versus Pacific-born population, which, as we now know, is 2/3 of the Pacific population. Over 90% of Pacific children are now born in New Zealand. Okay, so what we wanted to do now is use a representative population survey, the New Zealand Health Survey, to understand whether Pacific people with mental health conditions different from the overall Pacific population in terms of their age, ethnicity, gender, etc. So what are the demographic characteristics of those who are Pacific who have mental health problems? I'll get onto the mental health problems we looked at shortly. Then, as well as the demographic characteristics, we want to look at the socioeconomic characteristics. So do Pacific people who deal with issues related to mental health differ in their education status, financial situation, etc., household overcrowding, and deprivation from the overall Pacific population? What are the prevalence trends for adult and child mental health outcomes from 2011 to 2021 for the Pacific population? And building on that one, is there any evidence for an impact of COVID-19 on mental health in the Pacific community? Okay, so for this, we used a tailored tivaivai research framework built off the work of Te Moana Maua Hodges, and that's Mama Maureen there, that's right, in the green. So as part of her, I think it was part of her PhD, wasn't it? She developed this methodology for part of her master's. She developed this methodology for Pacifica, a Pacifica methodology for research. The research she was doing was mostly qualitative. So using the steps involved in making a tivaivai quilt as defining the steps in the research process. So it's kind of gathering the materials, sort of doing the data collection, putting things together, putting together the results, tidying it up, getting some review together, and then presenting it to the population. And then Jesse and others, including Troy, modified this for a whole population type and quantitative analysis. So this was, again, using integrated data infrastructure data. So Jesse added a step to this process, and then these steps were refined again through this meeting happening in December last year in Pararua, where Jesse beamed in by Zoom to come up with the 8 steps that defined that. So to define a tivaivai method specific for our project. It's not a generic one for either integrated data infrastructure work or for qualitative research, but for our particular project. And so these are the steps here, which I'll go into shortly. So the 8 steps that we did or are doing as part of our research. I'm going to talk about the 3 through 6, which are kind of the methods, the results, and the conclusions. The last 2 are about getting some feedback, which is happening now, and about presenting it to the world. And we're going to have a launch, which we're still arranging. I can't see the Teodoma is the top one. So that's the planning. That's the putting together our team and deciding exactly what we're going to do. The akaruru was the planning of the project itself. So that's getting together as a team and deciding on a project plan, putting in an application to get access to the IDI, and putting an ethics application to do the work. The patoki is a selection of the variables that we want to look at in this research. Te momo, the analysis of those data and the reviewing of those analysis. The tuitui, the key findings and the interpretation of that findings. And the akamania, which is the drawing of the conclusions and the recommendations, and also getting the internal peer review and putting this together as a final report, which is being finalized now. Ariki anga, the validation of the findings through the peer review process. So a draft report has gone out for peer review now. And as I said, the order is the presenting it to the world, which I say we'll have a launch, but there's a little sort of pre-presentation to you guys here now. Okay, so the source of the data. The New Zealand Health Survey, we access that through The integrated data infrastructure was linked to some census variables, 2011 to 2019. So one aspect here is that we only, the New Zealand Health Survey data that's made available in integrated data infrastructure stops at mid-2019, pre-COVID. So they go fiscal years 2011-12 to 2018-19. So we couldn't actually use those data to investigate the COVID question. So we also accessed those data through the New Zealand Health Survey Data Explorer. And as we're doing this work, an extra year got tacked on to that. So we're able to look at essentially 2 years post-COVID, which weren't complete New Zealand Health Survey years, because they were obviously hampered in their ability to go out into people's homes and do the research. But it was what we had available to us. And for the adult population, we were looking at 3 outcomes: doctor-diagnosed depression, and doctor-diagnosed anxiety, and self-reported psychological distress. For children, what we wanted to do is look at social emotional problems, which they asked as a question of the parents of the children. So that was doctor-diagnosed ADHD, doctor-diagnosed chronic disorder, doctor-diagnosed depression, I think, and they put that all together in one. However, as part of this process, what we discovered is the base rates were so low that it was impossible really to then stratify that to see if there's any differences between any groups. So we moved to looking at the Strengths and Difficulties Questionnaire scale. So the Strengths and Difficulties Questionnaire developed by Robert Goodman at the Institute of Psychiatry, London. So it's a measure of child behaviour across 5 different domains, which I'll get into shortly, where you get an overall scale score. You can actually also, what is most commonly, I would say, use where you put a cutoff on that score and saying this child has hyperactivity issues, this child has emotional problems, etc. But there's a couple of reasons why we didn't do that. One is that we get into the same problem of low base rates and not being able to stratify that by anything. And also there is a little bit of work showing that those cutoffs aren't necessarily valid for the Pacific community. So whereas I'm of the belief that higher scores on something still mean that that child, whatever the ethnicity, is experiencing more issues, has more symptoms, those cutoffs don't necessarily work particularly well for the Pacific population. And the other issue with that is it's only been, of the data that's in the IDI, we only had access to 4 years for us for our analysis, 2012, 14, 15, 16. So we're limited a little bit for children, could do a bit more with adults. So yes, those are the numbers there. So first of all, focus in on what's happened in the last couple of years with COVID and the interruptions to doing the New Zealand Health Survey. They aim to get 12 to 13,000 adults per year with population representative numbers of ethnic groups, such as Pacific there. But when you do that, you're down to below 1,000 Pacific adults, and in the final couple of years, you're down to sort of 600. Then we were able to link to the IDI. This is just focusing on adults here. You'll see that, sorry, taking a step back. In order for these data to get into the integrated data infrastructure, every individual who completed a New Zealand Health Survey had to have given consent for those data to be linked. And not everyone gave consent. Where they gave consent, the data is made available in the integrated data infrastructure. Where they didn't, it's not. So that's not a full population there either. So when we're looking at different factors associated with mental health, we were using those smaller numbers there of linked Pacific people. When we're looking at trends across time, we're able to use the New Zealand Health Survey Data Explorer and use the full population there. So whether or not people consented to have their data linked. Okay, so this is what we looked at: depression, anxiety, psychological distress. Using the Kessler 10, I'll get into that in the next slide. And emotional problems, peer problems, hyperactivity and attention problems, chronic problems, and prosocial behaviour, and the Strengths and Difficulty Questionnaire. These top 4, you add up to form a total problem behaviour score, which we also looked at. So essentially, we looked at 6 different things there for children. And just to give you a sense, That's the Kessler 10 on the left. I hope you can see most of that, even with the zoom thing across the top. So 10 questions. It's developed by Ron Kessler, Harvard University. He's a sociologist by background, interestingly enough, and the most cited researcher in the world at the moment. Okay, so 10 questions about depression, anxiety, and distress type symptoms. And for children, that's a list of the 25 items that tap the 5 scales of the Strengths and Difficulties questionnaire. So they rotate them through when you go through and ask the questions. So out to the, in parentheses, out to the right-hand side, you've got the actual scale the scale that taps to. And some of them are reverse coded, and some of them they have slightly different questions for young children. But they get a score of 0 through 2 there. You add them up to get a score of 0 to 10 on each of those scales. The Kessler, you get a score from 10 to 50, and there's a cutoff. Can't remember exactly where the cutoff is, but what was it? It was severe psychological distress is what we investigated. So those are our measures. And then these are the things that we look to see whether or not they were associated with our outcomes of interest. So we've got the demographic ones, age, ethnicity. So this is the particular Pacific ethnicities that they identify which, and they can identify with more than one, as many do, as we showed before. They also identify as European and Māori, as many do. Gender, place of birth, New Zealand, overseas. And then we looked a little bit, I won't go into this too much, actually, we looked a little bit at regional variation. What is it? 2/3 in Auckland and 80%, 90% in the North Island? Something like that. So at times, when we started, DHBs existed. So we looked at the 3 Auckland DHBs, then the rest of the North Island, and all of the South Island. And socioeconomic predictors, some of these came from census data, so level of education, median household income, labour force status, home ownership, household crowding, just looking at the number of people per bedroom, and level of deprivation. Combining in 1 and 2, because something around 50% of the population are in quintile 5. Okay, so what did we do? So what we did is we assessed association. So for the associations with demographic factors and socioeconomic factors, taking a step back, what I should have said right at the beginning is this is a descriptive study. Essentially, we're describing what's going on in the population. Assess associations between each factor and each adult outcome, logistic regression because they're binary, and each child outcome linear regression because there's a scale score. Weighted to the full Pacific population of adults and children using the weights that are provided to us in the New Zealand Health Survey. What are the prevalence trends for adult and child mental health outcomes from 2011 to 21? Tests for a linear effect of year within the IDI, or using the Health Explorer when we're looking across 11 to 21. We mostly use the IDI for this, I think. And then, is there evidence for an impact of COVID? Basically by looking at the linear effect. And what we investigated is whether the pooled estimate for, can only focus on adults here, depression, anxiety, and psychological distress differed in the 2 years prior to COVID to the 2 years post-COVID. Okay, so moving on to results. In terms of depression, the health survey suggests it affects 24,000 Pacific people. About 1 in 12 Pacific people have doctor-diagnosed depression. That's a lower prevalence than the non-Pacific population. It's barely increasing year on year, about 0.2 of a percentage point. It's 50% more common in women than men, which is, as many would know, once you get past adolescence or 2 adolescents, depression is more common in women than men. Twice as common in New Zealand born than overseas born. And fairly similar prevalence across the mid-adult years. And that's where you see the highest prevalence. Anxiety, very similar, 25 Pacific peoples in 2021, 2022. Lower than non-Pacific, slightly greater increase per year. So Going back a few years, there were fewer people reporting doctor-diagnosed anxiety than depression. Now it's roughly the same. Again, 50% more common in women than men, and highest particularly in the age 44, we're able to detect an effect, I should say.
As long as you're not inside.
Psychological last week. We have to get it back in. 38,000 Pacific people are estimated to have high psychological distress, and that's a higher prevalence than non-Pacific. It's increasing 1.3 percentage points per year, about 25% more common in women than men. No difference between New Zealand born and overseas born, and similar rates across ages. So quite different findings between anxiety and depression and the psychological distress. I'll get into why I think that is the case shortly. Yeah, so this is a lovely graphic that Anita's put together that summarizes all that and more. So across sort of gender, age, ethnicity. So I didn't go into the ethnicity so much. But, and like you can't see, we can't see, you on Zoom can, that's depression, anxiety, psychological distress, and that's describing the Pacific population out to the right-hand side. But yeah, we're finding high rates of psychological distress amongst Cook Island Māori, and whereas the diagnosed stuff is highest amongst those who are also of European ethnicity. Again, I think this actually shows a pattern. And again, another thing that shows a bit of a pattern, if you look at psychological distress, lowest in Pacific population in the South Island, yet when you look at doctor-diagnosed depression, highest in the South Island or second to highest in the South Island. But a $10,000 difference between those in annual income, between those with the disorder versus those without, which is actually one of the ones that's consistent across the three conditions. In terms of the socioeconomic correlates, no education gradient for depression, lower income as we showed, more likely to be unemployed, lowest amongst those living in overcrowded houses, and no deprivation gradient. Similar things, but slight difference with anxiety, no education gradient, lower income, lowest amongst those living in overcrowded houses, and highest amongst those living in the least deprived areas. So an effect of affluence going on here. Psychological distress decreases with increasing education. So with lower income, as we saw, more likely to be unemployed, higher amongst those renting, and no deprivation gradient for psychological distress. Okay. So these are just, again, going through a slightly more detail, I don't think I will go into, of the socioeconomic factors as they're associated with mental health in the Pacific adults. Children, got 6 panels here, one for each of the scales. Emotional problems, not changing over time, no gender differences, tends to increase with age. So and the 3 age groups, if to remind you, were 2 to 4, 5 to 9, 10 to 14. Hair problems, not changing over time, higher among boys, seems to be higher in counties Manukau. Hyperactivity, not changing over time, higher among boys, higher among very young children. This is something, Steph knows this literature better than me, but this is something that you would tend to see in all populations, the higher among boys things, and I think also the higher among younger children for hyperactivity and attention. Chronic problems showing pretty much the same pattern as hyperactivity. Prosocial behavior, that's the good one. Not changing over time, higher among girls, increases with age. So showing more kind behaviors. And putting together the first 4, nothing's changing over time. No evidence they were changing across more, well, taking a step back. Over time is from 2012 to 2016. So it's over time a decade ago almost. Higher among boys for the first 4, and higher among very young children, driven by the hyperactivity and the conduct problems. In terms of the socioeconomic correlates, no deprivation gradient for emotional problems. This is mostly about deprivation. Peer problems increases with increasing deprivation. and it is higher for children in rented homes. Hyperactivity increases with increasing deprivation. Conduct increases with increasing deprivation. Prosocial behavior decreases with increasing deprivation. And when you put the first four together into an overall scale, increases with increasing deprivation, which again is something that you'd see typically with strength of visual questionnaire scales in non-Pacific populations as well. Okay, I did leave this in. I thought I'd taken this one out because it's got a few.
Just skip it.
Yeah, I'm just going to skip it. It's got a few things for it. But anyway, hard to focus on it anyway. Okay, COVID. Okay, so what we've done here is shown you the percent of people with each of those conditions, depression, anxiety, psychological distress, from the pre-COVID period, 2018, 2019, and the in-COVID and post-COVID period, 2020, 2021. Do you think there's any evidence of any effect there? Maybe with anxiety, you think, okay, yeah, it's going from sort of 5% up to 9%, kind of carrying on the same trend, but going up by that amount. When you're down on the error bars, that's what you get. So I don't think we've got any evidence that COVID has had an effect, but then we're pretty underpowered to detect it.
Yes.
So, summary of the key findings. There are lower prevalence of doctor-diagnosed depression and anxiety, but higher prevalence of self-rated psychological distress. This made some sense to me because I think what it represents is access barriers. If you ask about people's symptoms, as they do with the psychological distress, you get high reports of symptoms going on. But if you ask, has a doctor ever told you that you have depression or anxiety, you get fewer people saying yes, because they haven't seen a doctor. And this is a consistent finding. If you remember back to the preamble, I went through what was found in the 1990s. That was highlighted then as well. Half the diagnosis, but higher rates of psychological distress. I would say the socioeconomic correlates are largely expected, although affluence sometimes associated with high rates of doctor-diagnosed depression and anxiety, which again, is this a better access thing going on? So it's those who are more well off who are able to access services for these things, and so can answer confidently yes to the question, a doctor has diagnosed me with depression or anxiety. New Zealand Born report more doctor-diagnosed depression and anxiety. There could be an access thing again, I'm not sure. Child behavior issues steady over time. I would say demographic and socioeconomic patterns about is what I would expect. No evidence of COVID impact, but not well powered to detect one. But what I've seen actually in the New Zealand Health Survey generally, I've looked at mental health and I've looked at obesity, and I haven't seen much evidence of the COVID impact, as has been shown overseas. Okay, Akamania, implications and recommendations. So in terms of policy, so we think Pacific-led initiatives that focus on Pacific with mental health problems and improve service delivery for Pacific would be very, very useful. And there's potential for agencies and communities to work together on this. So these are a couple of strategies that my colleagues are more familiar with than I am. The all government wellbeing and Pacific language strategies to support resilience in Pacific peoples. I have to highlight this one. Poverty is a driver, right? So improving social conditions can improve mental health, I think. In terms of mental health workforce, strengthening multi-ethnic approaches to workforce training and development reflective of an increasingly ethnic diverse Pacific population. As we mentioned up front, 41% of the Pacific population are multi-ethnic. That should be reflected in the workforce that is treating them. In terms of Pacific data research, I would say we've had a few chats to, well, kind of chats to the New Zealand Health Survey about this. It's not well placed to investigate correlates or trends of low prevalence outcomes, such as mental health, among minority population groups. And they're aware of this. They know, I was talking to Maria Turley, well, she was mentioning actually that once you start breaking down by things in the New Zealand Health Survey, you run out of numbers pretty quickly. I think for our purposes, oversampling could address this, and there's fairly standard statistical techniques to get you back to a representative population afterwards. When a colleague asked about this, it was suggested there was cost implications for this, but I would argue that oversampling is a heck of a lot cheaper than a Pacific Focus mental health survey or another full population mental health survey. And again, this is just about what's going on in the population. It can't say anything about why these things are happening. We've speculated that it may be access issues with, or I've speculated, I'm hot on this one, that it may be access issue related to why you're seeing high rates of diagnosed depression, anxiety, and the role played by immigrant status. And I think that's us. Thank you.
Thanks, Barry. Do we have any questions?
Yes, Peter.
Yeah. Sometimes it's argued that migrants actually have a bit of an advantage because they hold together, like the Pacific people got the churches, got their community groups, and they got the language and their cultural customs. So in many respects, they're protective, even though they're going to a strange culture and society and they're in the lower socioeconomic group. So I'm just wondering if there's any way in which one can factor that in, that the low base rate is, yes, they can't get to a doctor, but it could be that there's a lot going for them, despite all the adversities of going to a new society. And is there any way of picking up the social capital that they have, or was that just impossible thing to do?
I don't think it's impossible, but I don't think it's possible with these types of data. I think it's a really good point. And I'm harping on about access. It could be that they're getting support from their community. Right. So it's not so much an access thing. It's we don't need to go see a doctor. And from these data, you just can't tell, right? That's why my final point about qualitative potentially work that needs to be done. I don't know if you guys wanted to add anything about the support networks that Pacific have.
Sure. So I love everyone. That's right. I think I want to, I guess, take a step back and go right back to the reason why we use the tivaivai for this project in particular. And the main thing, and please, Jesse, Stephen, and Troy, the tivaivai as a methodology kind of allows us to look at the data differently, not in conventional terms, but it, models like that sort of place emphasis on what we've actually put in a report, sees tangata, and we use that word deliberately because in Pacific, tangata is not just a person or a number. It actually has connections, and not just connections to people, it's connection to land, much like the people Māori have, and also connection to spirit. And so what you're referring to about connections, it is within the family, but there's a particular, I mean, well, I like to say in a lot of Pacific families, whether they sort of practice this or not, but they're connected to their ancestors. And so all of that sort of drives how they behave. So whilst there is definitely access issues, but there's also a bit of it to do with their beliefs and what constitutes a mental health problem, or what is a problem. Because we actually didn't look at this, Barry, but I suspect that they're going to the doctor, but not necessarily for mental health problems, because the doctor might not understand what they're saying, and so they're presenting themselves with physical health problems. It's why we've got high diabetes, high gout numbers, but as you can see in our mental health numbers, it's lower. So there's that going on as well. So when you're saying about connection, yes, definitely, and it's kind of hard to unpack that in this meeting, but there's definitely a whole lot of that going on. And for myself, the issue isn't this. The issue really is how you place that in a system that doesn't necessarily recognize it or know how to deal with it. So there's some of, and then hence why with oversampling we want to promote oversampling, but also stratification. Rather than look at our multiple ethnic groups down to the 18, perhaps look at round country versus Pacific only, that sort of stuff that we sort of talk about but doesn't get picked up. But those sort of different ways of thinking would help to promote the narratives of Pacific data, which we hope will come out in our study. So like I said, we particularly use the tivaivai for that purpose of not moving away from convention, but building in the Pacific narrative in a way that we can see the Pacific people. Troy and Jesse, you want to further add to that? So I'm not sure if I answered your question, but it's just, yes, so definitely there's that sort of cultural things going on, and until you unpack it, but I think for me as a researcher, Pacific researcher, there needs to be a large body of us talking about this stuff. We need a lot more, not just numbers, but those narratives, because I think a lot of it gets lost in the more Western constructs of how you talk about data. But the more we talk about it in the Pacific ways, then the more people start to think, oh, okay, so can we think about this data differently? Can we tell the story differently? And then for me personally, then I believe that's when changing the system, so to speak, can happen, and we can realize those positive aspects, but not just for the sake of it, saying, oh yeah, but they do this, so it's positive, but in the way of saying, so how do we then understand it so that they get into, also that people can talk about it in that framework, but not talk about how it doesn't fit a different framework. I don't know if I made any sense, but Jesse and Troy.
I think you described it well, Ata. That's good. I just wanted to say I enjoyed developing this tivaivai taorei model. But the thing is I'll start with the tivaivai model. The thing about the tivaivai model is the Māori terms are important in that they display the cultural complexity that underlies this. The thing I like about the tivaivai is it's, on the face of it, it's a simple quilt pattern, but it's derived from a cultural complexity that underpins it, and it's, when you list the items in English, it seems like a straightforward process of analysis, but underlying that are the things that contribute to the stories that Ata has just alluded to. The only other thing I wanted to talk about was the access patterns of access. Troy and I, we wrangle with this because on the one hand, you have this way of looking at it, like the community is set up to embrace people with mental health issues and care for them. But on the other hand, so it's like a transferal of care, burden of care to the community in a sense, but it's kind of like a not funded transference is the thing. So people are less likely to attend specialist mental health care services. But what happens often is that they end up there if the community, they're too severe for the community to handle. And so Pacific people in mental health services often have greater complexity. So yeah, that's the only thing I wanted to point out. Troy?
Yes, that's good.
Thank you. And thank you also, Ata, for pointing out that at the beginning of something that I completely missed, really, is that we have a Pacific population that is going to the doctor a lot for things such as diabetes and other things. And maybe it's not being recognised, the mental health problems that may be being presented whilst they're in those settings. Which comes back to the unfair treatment point early on, perhaps.
Yes.
Firstly, thank you all for really interesting research and presentation. It's sort of, I don't think it surprises anyone when you go, oh, poverty is one of the key drivers, but I think the more evidence that we have, we can go look to try and get something to change. But also the question of access, and I'm working on a project with Samoan women with breast cancer, and that access to care and the cultural inappropriateness of the care and all the same thing. But that's not, so that was just a thank you. But my question was around the gender stuff. Is it purely binary? Is there any sort of MVP, FAF? Like, is there any breakdown beyond male, female? Is it possible?
Is it possible? Then, now, no, now possibly, but you're going to run into really small, quantitative, you're going to run into really, really small numbers. In fact, I don't know if any of you IDI users out there have noticed, but I went to the latest refresh, or the second to latest refresh, and there are a small number of non-binary people in the personal detail table, gender variable. And when I say a small number, I mean less than 100 out of a population of 5 million. So, and this would be because some access services picked up on that, right? Not based on the census, which did ask about it for the first time. Post-census, there's going to be more possibility for that. So, you know, needs to be done. But with kind of broad brush, whole population looks at things like this, or survey look at things, not possible, unfortunately.
Maybe that's another oversampling.
Yeah.
Solution.
Well, if I can convince New Zealand Health Survey that, yeah. But we look back at the mental health survey. There was definite oversampling there, and for good reason. 2,300 for the overall claim sample is the New Zealand Health Survey compared to less than 1,000. Sorry, Lisa.
I don't know. This is just a comment. I don't know if this helped your advocacy, and maybe you've already heard about this example. But for oversampling, so we were using the PAC data, the Survey of Adult Skills data. Our Ministry of Health, we said to Ministry of Education, sorry, we can't really do any breakdowns of specific people because the sample is so small. And they said, funnily enough, that you should say that because next PAC wave, they're oversampling. So if you want an example of a government agency that's actually done it.
Thank you.
Oh.
Yeah. I do want an example.
I mean, I do it for Māori population, so why not also this?
Well, they do oversample to get a population representative sample, but they don't oversample to get an oversample, if that makes sense. So they're because response rates are lower, they do target some groups more than other groups, as we do when we run surveys. We actually end up with an oversampling when we do it. But anyway, sorry, Leon, I saw you there.
Does the New Zealand Health Survey contain questions about service access? And if so, are they useful for this?
Good question. Yes, they do.
They do, yeah.
Yeah, it's one of the key outcomes, actually. We did not look at that. We can. Their lab's just over there. Yeah. Why did that miss us? Yeah, good point. Yeah. Yeah.
Which of the tivaivai steps is this, the internal peer review?
The internal peer review is that's part of the akamania.
Yeah, that's all right.
Yes, yes, yes. The external peer review is happening now. Yeah.
Just one final question about stratification. Can you, if you find no interaction effects, can you then proceed to sort of assume some sort of linearity and just put age as a factor rather than breaking it down, or is it
I mean,
more than that?
We specifically set out just to look, was there a difference here? Was there a difference there? We didn't show it actually. We did look two-way where we could, age by something else, gender by something else. That's the only thing we did though. I mean, if you're taking from a sort of modeling point of view, yeah, that's exactly what you do. But we weren't modeling, we were just having a look. Oh, okay. Oh, this is where I might pass over to Troy. The 1990s, there was early work in the 1990s. Where was that from, Troy? I printed out the introduction, so I can find that out for you, Jeffrey. But off the top of my head, I don't know it. Troy, do you know off the top of your head?
No, that's something that I kind of put in the report and then moved on. But I think some of the stuff from the late 80s as well was from the early housing commission work as well, where they talked about how housing and state of housing was actually contributing to poorer mental health outcomes, with Pacific being in the group that is more likely to have higher levels of poor housing. So I think that's where some of that came from. And then, yes, that was probably in the 80s, published in the 90s.
Were there any, can you remind me, New Zealand born effects?
Yeah, so New Zealand born had higher rates of doctor diagnosed.
I was wondering if there was anything linked to age there in terms of like, were there
Did we do
older
New Zealand?
slash
We didn't do
younger?
New Zealand born by age. But having said that, this is another thing that we did not do, and is worth pointing out, that we looked more or less factor by factor, and New Zealand born is markedly different by age. So
Yeah.
the overseas born New Zealand Pacific population are older.
Yeah.
As I said, the children, 91% were born in New Zealand. So is the New Zealand born effect an age effect? We didn't quite see the same things with age New Zealand born.
Yeah.
That if we were to really tease it out, that's what we'd have to do. That's really the point. But we know we did not do that.
On that kind of idea, the gap in income, was that adjusted for gender, or is part of that seeing more mental health challenges among women and women earning less?
It's exactly the same. Yes, I suspect it is. Yeah.
Double fun.
And possibly that's the pathway, right? Yeah.
Did you think about using quilts as a supplementary data source for children, even though I know it's only one cohort of children, because they have experience in difficulties questionnaire and quilts?
They do, and the Pacific numbers in Gwyn's are 1,000.
I think a little bit under, but yeah.
Yeah, so
Maybe
actually that's
800?
bigger than
Yeah.
New Zealand Health Survey's got. No, we did not think of that. That's actually not. You've still got connections with Gwyn's.
A little bit.
A little
Yeah.
bit. That's not a bad idea, actually. Albeit, one cohort being followed over time, as opposed to looking at trends across time. But that's a really good point.
Yeah.
And Steph did a PhD on the
Strength and
SDQ
difficulties, yeah.
in the Growing Up in New Zealand study.
Yeah.
So knows the data really well.